Thank you everyone for joining us. Those who have joined on time, thank you so much for that. Today we are going to listen about managing respiratory symptoms in a palliative care setting. As Ripriya told, Dr. Rajam is the right person to deal with this session because she is a pulmonologist and a palliative care consultant in Mumbai, working with Bhatia and Hinduja Hospital. She has done her training in palliative medicine from TIPS years back, and then she's doing her post graduation from Cardiff University, UK, and she's a very eminent faculty in many national and international platforms, especially propagating palliative care among pulmonologists as well as in the emergency medicine and critical care units, especially. Many managing symptoms as well as legal issues in terms of withdrawing care, the interventions, futile interventions, etc. So, welcome, Dr. Rajam, for this session. It's very, happy to see you after a long time. I think we've not seen for quite a long time now.
Yes, that's true. I think the last time we saw was during the September
Yes,
training, right?
yes, yes, yes.
Yeah, so it's been a long time. Thank you, Pallium, once again for giving me this opportunity. It's nice to see there seems to be people from all over the country, and I think there is somebody also from outside India. So, what is the profile of the doctors who have joined this session, Sri Devi or Sri Priya?
Most of the doctors are from India, but various parts of India as usual. Dr. Ian is from UK. He's there. He travels a lot so that he gets proper connectivity to attend the session. So that's a wonderful thing that I can talk. He travels a lot so that the internet connection is uninterrupted during the session and he logs in on time. So
Thank you. Thank you for that, and a very warm welcome to all of you. Uh, as I always mention in the beginning of any of my talk, I think I learn a lot from people who join in and from various circumstances that you all work. So please keep it interactive. Do not hesitate to interrupt so that this session can be interesting. So feel free, raise your hand or chat, put the messages on the chat so that Sri Devi or Sri Priya can pick it up, or I can also pick it up during the talk. What is important is to see to it that we are able to learn from each other, and it's always interesting to do that. So, without wasting much time, I'll just share.
yes, we can see.
Okay. Yeah. So, as Sridevi introduced me, I am a pulmonary physician, but life changed and took its course about 6 to 7 years ago, and I did the training in palliative care. And what I can say is that a lot of things had to be unlearned before I became a palliative care physician, and it's been a very interesting journey. And I think now I feel, and I think there has been enough feedback from patients and caregivers that there is a value addition in actually marrying the two specialities of palliative care and respiratory medicine. So as we start, what I would like to tell you is it's very important for us to realize the significance and the need for palliative care in any other non-cancer branches. I think world over there is a understanding that palliative care is meant for patients with advanced cancer, and therefore historically as it started with cancer, it is considered that only cancer patients benefit from palliative care. Having said that, this slide is put up to emphasize the statistics of Indians suffering from non-communicable diseases, which can also be changed as non-cancer diseases. So if you see, a large part of Indians are affected by lifestyle diseases like diabetes, like hypertension, heart diseases, stroke, and respiratory tract diseases, and that also includes TB. Yes, in India, we do add about 1 million new cancer patients every year, but the amount of people suffering from other non communicable diseases, lifestyle diseases, is way more. And we must realize that all these conditions are only controllable, these are not curable, and these go through a very protracted, long, chronic illness. Sharon, you wanted to say something?
No, your sound was not coming through. That's why
Now?
now I can hear. Yes, now I can hear, ma'am. Yeah.
Okay, sorry. So what needs to be what one needs to realize is that the number of Indians affected by non-communicable diseases is a large population of Indians. These have a very prolonged course of illness because you're diagnosed to be diabetic at 40 and they can have a lifespan till about 60 or 80, or hypertension or heart disease or renal disease or COPD. So please remember that the burden of non-communicable diseases is all the time rising in the country, and non-cancer conditions also require palliative care. So these are just the incidences focusing on the respiratory conditions. That is the rise of TB in this country, because we also have multi-drug resistant, extremely drug resistant, as well as totally drug resistant tuberculosis in the country, which can form a large chunk of healthcare time, and the time and energy spent by pulmonologists in counseling, hand-holding these patients and rehabilitating these patients back into the vocational front. Similarly, if you see, the trend of COPD as well as interstitial lung disease in the country is on the rise. So more and more patients are affected by these conditions, and these conditions run a very prolonged, unpredicted course, and these patients do have a high symptom burden, therefore meriting the need of integrated care along with the pulmonologist. And how many sessions have you all had in this training? You must have all seen this slide. That's why I don't want to spend too much time on this. But if you see this slide, if you know, the slide A is that of sudden death. But today's topic, we will focus on the slide C. And what is in slide C is typical life experience of a patient with any organ failure, be it the lung, the heart, the kidney, or the liver. So these patients slowly have a deteriorating quality of life, and every time they get admitted in the hospital is for an acute exacerbation. And if you realize, when these patients go home, these patients do not have the same quality of life as they had when they got admitted. So these patients lead a deteriorating quality of life, and slowly they reach their death. So if you see, from the time of diagnosis to the time of death, it could be in years. And usually non-communicable diseases, these patients live for 10 to 15 years after they have been diagnosed. And these 10 to 15 years could be punctuated by frequent hospital admissions. We as doctors are trained to look at acute admissions. We never realize what the patient and the family go through once these patients go home. Are they able to walk? Are they able to eat? Are they able to go to the toilet? Are they able to self-care? Are they mentally, physically, emotionally, socially, and financially in a better place? So this is the main aim of palliative care, where we handhold the patients and the relatives, they address their total pain, look at them holistically, and decrease and alleviate suffering. What have we become doctors for? We are not able to save and cure all illnesses. If you think about all the medical conditions that you're able to cure, it's probably the infections that you're able to cure, which is one third of the infection of the illnesses. If you realize, one third is only controllable and the rest of the one third is incurable. So largely two-thirds of the conditions we see need the palliative care. Yes, in infections like a pneumonia or an abscess, we treat the patient and the patient returns to a good quality life. But in patients with organ failure, they keep falling ill and they keep having poor quality of life till death. So in turn, they lead a prolonged period of time with very high symptom burden. And that's exactly what the ethos of palliative care is, because they endure suffering for much longer. So it's very important to realize that non-cancer conditions require our attention as much as that of cancer conditions. So if you think of a chronic illness, like falling off a skyscraper, the manner in which you land depends on the way you fall. So it is the onus of physicians who know conditions like COPD, like interstitial lung, like chronic renal disease, or cirrhosis of the liver, congestive cardiac failure. As a physician, we know the natural course of this illness. So it is our responsibility to educate and inform the patients and the caregivers in the natural course of the illness. Hence, if the fall, that is the deteriorating condition of the patient, is punctuated by timely, sensitive, unhurried conversations, the patient and the family will be better prepared for an emergency. Please remember that all of us should will and sensibly learn to swim in a calm sea. Nobody wants to learn to swim when the sea is in a storm. When the patient is acutely ill in an emergency, that is the wrongest time to talk to relatives because they are stressed, they are emotionally distressed, the patient is suffering. If you sit and talk to them about what you need to do, what is ideal, nothing is going to register. But if a patient with a chronic illness whose trajectory and whose natural course is fully known to the doctor who is treating, that it is the onus of the doctor to foresee and foretell emergencies, prepare the patient and the family, and discuss these situations much in advance so that the patients also have the time to process and analyze what they need to do. Okay, so therefore, what we in the palliative care encourage is as early integration of palliative care along with the curative treatment. Very often, hospital consultants feel, oh, why are you calling palliative care so early? Are we giving up on the patient? No. By definition, palliative care is to address health related suffering. And I'm sure all of you by now have looked after the medical health of a loved one, grandfather, grandmother, you know, in-laws, or even parents or siblings. You know the amount of medical stress even we doctors go through when we look after our family members. Imagine what happens in a non-medical household. The stress is at all-time high. And this is exactly what palliative care tends to address. We are not saying stop curative treatment. We are saying to marry and integrate palliative care into each specialty so that as the curative option fades, the palliative care option is available to the patient. Second, now what happens? It is when the curative care ends, they think of palliative care. So it's almost like the patient is being abandoned by their primary consultant. In the situation where you integrate palliative care as well as um, curative care, the transition from the curative to the palliative care is smooth. Patient's family and the patient is already introduced to the palliative care team and they don't find that team to be new. Plus, even if we are not able to change the outcome of that illness, we at least make the journey much more bearable for the patient and its family by addressing psychosocial, emotional, financial and other issues of the patient, because it is not just physical suffering. The patient and the family goes through a lot, and if we are able to take care, it also helps the primary consultant focus on what he needs to do, disease oriented, and we look after everything else. So this is the change we need to bring about, because palliative care handholds the patient, the family through the journey, and the family after the patient has died, which is the bereavement care. So if we know the patient's values, beliefs, then we can even treat him much better at end of life, as well as look after his relatives once the patient has died. So very often, this is a very important question. Like I said, the biggest obstacles for palliative care is patients, hospital consultants. They feel referring to palliative care very early is giving up, and the patient feels, oh God, am I going to die? And referring too late, we don't have the time to form the rapport with the patient and the family, and therefore we are still grappling and we need to discuss very important decisions as to how the patient would like to be treated at the end of life. So this is a very important question that we need to think in our minds as to what is the ideal time of referral of these patients to palliative care. And one of the questions that has been researched in UK is, when you have a patient sitting in front of you, in your mind, think, will you be surprised if this patient is not alive in the next 1 year? If the answer to this question is no, that you think the probability of his death is very high, that is the time to refer this patient to palliative care. And to make this simple, there are indicators which has been given in the Blue Maple document prepared by Manipal Hospital, as well as the gold standard framework from England. Both these documents can be shared by Pallium India to all of you participants, which clearly tells you indicators for referral in every chronic condition: renal, liver, heart, motor neuron, Parkinson's, stroke, and also lung. So just to tell you, the indicators for referral of a patient by a pulmonologist to palliative care in COPD is if the patient satisfies any two of this criteria, which is recurrent hospital admissions, which is more than 3 in a year, or when he's so short of breath that he cannot even grade 4 or 5 MRC by walking 100 meters on ground level, deterioration in lung function, 24-hour usage of oxygen, multiple comorbidities, and one hospital admission requiring intensive care. So if the patient satisfies any two of this criteria, the probability of him living for the next 12 months is low, is guarded. Therefore, since the prognosis is guarded, it is the time to start referral. Let him get introduced to palliative care so that his quality of life is improved, and the focus should be on quality, because we are not able to cure the underlying condition. Okay, any questions? So these are the two documents which I'm sure Pallium India can share, which gives criteria for referral in each and every chronic illness. Because please remember, illnesses like Parkinson's, illnesses like dementia, illness like interstitial lung, illnesses like CKD because of diabetes, blood pressure are not curable. Yes, and not every patient can undergo transplant. In that event, it is still the right of a patient to be comfortable, to be treated with dignity, respect, and we should do what the patient wants us to do and not what is in our experience, because what is good for you may not be good for the patient. Because you must remember that there is nothing blanket which is good for all. Please remember that you need to ask the patient his or her choice. And that is one of the first pillars of medical ethics. Autonomy is the right of a human being, and we must insist on asking the patient what they want. In order that the patient is able to decide what he wants, he needs to have full medical information in a language he understands. Otherwise, how can the patient say, decide anything unless he understands his illness? So please remember, it is our onus to talk to our patients, and it is very, very important to master communications. And it is a skill that we all need to learn and need to continue to practice, because it can be very difficult to start talking about death and dying when you're not trained about it. You get uncomfortable, you don't use the word death, you keep beating around the bush, and it completely dilutes the situation. So in another way to emphasize how people are dying in the world, there's a research published in this 2010 paper, where out of patients admitted in an intensive care unit for acute exacerbations of COPD, acute exacerbation of breathlessness, or in an emergency situation, 80% of cancer patients received palliative care. Less than 2% of non-cancer patients received palliative care. And this is a situation in the West, and we are at least a decade or so behind the West. And what else was noticed was patients who did not receive palliative care received unnecessary, futile, aggressive medical treatments towards end of life. More CPR, less symptom documented, therefore less symptom controlled, and therefore patients in short died in pain. And all of you therefore probably already know that today India ranks 59th in the quality of death index. Our people are dying poorly. our people are dying, suffering. So there is also one of the teachers in Institute of Palliative Medicine in Calicut has said it very beautifully that in India, the poor die in neglect and agony, the middle class die in ignorance and agony, and the rich die on the ventilator, yet in agony. So it's not that the rich in the country get good medical treatment. Because they can afford it, they keep getting subjected to more and more and more, because there's so much that can be done in modern medicine. But what we need to stop and think, is the new treatment or is the aggressive treatment or life sustaining treatment in the best interest of that human being? That is what we need to think. And what is his choice? What would that person want us to do? And even if we admit patients in the ICU, there has been research to suggest that only 25% of patients are alive and well after a 6 months discharge from ICU. We as hospital doctors don't even know what happens to our ICU patients once they go home. Just because the patient is alive doesn't mean he is well. So we calculate everything in survival. What we need to calculate is quality of life. And we have realized that these patients, almost close to 70% of patients are, 40% of patients are actually dead in the first 6 months after discharge from ICU. So is ICU admission, was it merited to that patient? The problem also is the need to constantly do things. Imagine spending your last 6 months in and out of hospitals, in and out of ICUs. Is that what anybody wants in this world? Or you want to be comfortable in your own house surrounded by people you love? For this, we need to ask patients what they want. Considering the fact that their illness is incurable, is this how you would like to live your life? Or if you have another choice of comfort care, quality of life, is that how you want to give? So patients need to be asked their choice and patients need to be given their choice. And palliative care is probably something which is never discussed. So patients are not even aware that they can choose another thing except keep coming back to hospitals. So when you have a patient with symptoms of respiratory, which most common is cough, breathlessness, you know all these things need to be done. History, examination, X-ray, ECG, echo. What needs to also be done is pulmonary function test. It is a very undervalued test and it gives you exactly how well the patient's lung functions are. So lung function is very important, and an arterial blood gas and CT scan helps you to detect the exact anatomical, physiological, and functional status of the patient's lung condition. Then, because with numbers, you can actually predict the outcome better, it's important to insist on a lung function test. And very typically, our training is so cure driven that we only ask patients, is your cough better? Is your breathlessness better? Are you eating? Are you walking? What we do not address, and that is what palliative care has taught me, is what happens to a patient who has chronic breathlessness. So if I can take a moment of all of you, sit back, take a deep breath in and breathe half out. At that level, if I ask you to take another breath in, so for example, and then when you breathe out fully, there is room for you to take a second breath. But what I'm asking you to do is breathe out half. Take another breath from there, again breathe out half. That is how our patients feel every second of their life when they have advanced COPD or advanced interstitial lung. So imagine being all the time, 24/7, 365 days, year after year. So it's an extremely difficult situation. And the things we do not ask the patient is how it has affected his daily life. So if a person is completely breathless, he is therefore bed bound, probably room bound and house bound. And there is a lot of anxiety, frustration, irritation, anger, the fact that he's dependent on his family members, he cannot do anything without help, is all that is going on in his mind. And we never ask. Because we never ask, we never know what the patient is suffering. Correct? So we need to change the way we take history taking of a patient who has breathlessness all the time. Instead of asking, are you breathless? Is your breathlessness better? We need to ask him, what has he stopped doing to avoid breathlessness? Or how has his life changed because of this breathlessness? So he then will come up with, say, I can't even open the door, I can't pick up the phone, I can't talk full sentences on the phone. If I have to go to the toilet, I have to depend on a family member. So there's so much loss of dignity, and our patients die a social death even before a physical one. So the way you ask questions, open-ended questions, and questions leading to lifestyle of the patient, that's when we will come to know how the patient's life has changed. If you ask them closed questions like, is your breathlessness better? Are you less breathless? You're not going to get the answer that, sorry, I can't, doctor, I can't even go to my garden, or I can't play with my grandchild. Small, small things, but these are the pleasures of life, which we are depriving our patients because we never ask them. So this brings us to this beautiful model which has been described and which really explains what our patients are going through. Imagine a patient is breathless 24/7. He is breathless because of his underlying pathophysiology of COPD, congestive cardiac failure, or interstitial lung disease, or uncontrolled asthma. When a person is breathless, he will use his extra accessory muscles of respiration. His work of breathing is more, and there will be anxiety because a breathless patient is going to be sitting in one place, and the only thing that is overactive is his mind. So he will wonder whether how much money the son is spending, the daughter is spending all the time next to him, her life is getting ruined, she is not able to focus on family, I'm troubling my wife. And that anxiety, the fear, the guilt, all this is playing so much, which only feeds to his breathlessness. So an anxious patient who is breathless is going to get more breathless. And therefore, he will start doing less and less of physical activity. So he says, oh God, if I walk to the toilet now, I'm getting breathless. So let me not walk to the toilet. Let me put a diaper, or let me keep a bedside commode. And by walking less and less, he uses less and less of his muscles. So clearly, when you do not use the muscles, you lose the muscles, and the patient becomes deconditioned. So his functional status becomes poorer and poorer. And our patients are caught in this vicious cycle of being breathless, being anxious, and therefore walking less, and therefore losing even more muscle mass. And diaphragm is a skeletal muscle. It also becomes thin. So therefore the patient now, what he could walk 10 steps is not even walking 2 steps. And this is where the integration of palliative care along with pulmonary medicine helps, because palliative care is a multidisciplinary team. The pulmonologist looks after the breathing, the physiotherapist looks after the functioning, and the counselor can come and look after the thinking. So if the patient is anxious, if the patient is scared, if the patient is scared of dying, if the patient is scared of how he is going to die, the counselor can address those issues. And the physiotherapist makes him strong enough to do activities of daily living with less effort. We may not be able to solve everything, but by training the patient in relaxation breathing, by training the patient in using accessory muscles better, by training the patient to walk those 5 steps, 10 steps to the toilet, it improves the dignity of the patient, saying, yes, I can walk to the toilet alone, or I can sit with others and eat a meal alone, or I can finish one sentence on the phone. So we are focusing on the quality of the patient's life, because these small things make a difference. And we take all these things for granted. It's only when we lose these abilities, we realize how important it is for us. So our patients very much value to be able to do these small things on their own. So that brings us to the entity of chronic breathlessness syndrome, which was coined in 2017. Now, what is chronic breathlessness? A patient who continues to be breathless despite optimum medical treatment for his underlying pathophysiology. And when this breathlessness affects him psychosocially, physically, emotionally, and spiritually. So when it's interfering in his daily activities, that is chronic breathlessness syndrome. So all those patients who are advanced respiratory diseases, who have advanced cardiac illness, for example, 10% ejection fraction, 20% ejection fraction, those are going to be breathless despite oxygen, despite diuretics, despite bronchodilators, despite nebulizers. When they continue to be so breathless, That is chronic breathlessness syndrome, when it is the completely under the purview of palliative, to cloak the symptoms, how to cover the symptoms and support this patient and the family. So what can we do to these patients? There are a lot, as doctors, we tend to focus only on medications. Write out a prescription, our job is done. But when in palliative care, the beauty of the multidisciplinary team, the beauty of how much non-pharmacological can help the patient and the caregivers. So you give a list of to-do lists to do for the caregivers. They also feel involved in the care and not just dial the ambulance and rush the patient to hospital every time the patient gets breathless. So there are many things you can do to the patient. You can first teach the patient relaxation breathing techniques, loose clothes, well ventilated room, a battery operated fan. If you Google search battery operated fan in chronic breathlessness syndrome, a lot of research has been done by just blowing that air into patient's face. The sensation of breathlessness becomes less, the need for hospitalization becomes less, patient then becomes more in control and comes back to his baseline level of breathlessness. So small things help the patient. Also, how the patient should plan his day. So first he needs to plan what he wants, then he needs to prepare, and then he needs to pace. For example, I can give an example of cooking. Suppose a patient enjoys her or his cooking. What we normally do, we first keep the vessel, then we go get the oil, then we go get the seasoning, then we go get the vegetables. Instead, these patients should get assistance for somebody to plan everything for them. Then they can just go and sit there and finish that. So it gives them the joy that they were able to make something for the family. So whatever pleasure they get, we should see to it that we can help them achieve that target. So it's a much more satisfying life for them. So a lot of small things can be done to encourage the patient so that he feels useful. Otherwise, these patients feel useless and they feel burdened and they feel a loss of role in their own house. At one point, when this man used to run the house, has built the family, is now reduced to a corner of the house. So his whole dignity, his respect, his position in the family is also lost. Pharmacologically, you will all know about the bronchodilators, steroids, nebulizer, antibiotics, etc. Point of caution here is oxygen. And oxygen is also a drug. So please use oxygen cautiously. In the COVID times, we have seen how people have died because of lack of oxygen. That's also because of the unnecessary abuse of oxygen. Any patient who is breathless, the first thing anybody thinks of is to put in on oxygen. Please check the oxygen saturation. You need to put oxygen, supplemental oxygen, only if the oxygen saturation is less than 88. Because if you remember the oxygen dissociation curve, below 88, there is a sharp fall in the arterial partial pressure of oxygen. So if the oxygen is above 88, please do not start the oxygen. Instead, use other non-pharmacological things like relaxation, counseling, massage the back. Maybe the patient has heard a horrible news. So try to talk and distract the patient before you put the oxygen. Please maintain oxygen between 88 and 92 in patients who have a chronic lung illness. You do not need a 98 for the patient to feel better, because unnecessary oxygen also causes damage because of the nascent free radical that the oxygen supplies. That also damages the lung. The other important thing that we use in palliative care to palliate the symptom of breathlessness is morphine. Morphine is an opioid. It is used in the control of pain, especially cancer pain and severe pain. But in very small doses, it is an extremely safe and effective way to reduce the sensation of breathlessness. It reduces the work of breathing. The patient feels calmer. The patient feels breathlessness has decreased from a respiratory rate of 35 to 20 or something like that, more towards the natural amount of breaths per minute. It does not cause respiratory depression or increase in carbon dioxide if used in the window of safe low dose. We are not talking of doses that is given for pain control. We start very slowly 2.5 milligrams orally if the patient can take twice a day, and slowly increase, never exceed to more than 30 milligrams in a day. And please remember, you must prescribe laxatives, because the smallest dose of morphine causes constipation. And imagine a patient who's breathless trying to evacuate his bowels and pushing in the toilet is not a situation we want. So you must prescribe laxatives, and for the sake of the patient's comfort and quality of life, it is important to evaluate these patients for low dose morphine. And if you feel, the counselor feels that there is anxiety, then you must add lorazepam. And if there's a panic attack, you can also add morphine with midazolam. Because please remember, our intent is comfort. Our intent is the quality of life improvement. And anyway, the patient is so advanced in the illness. Please do not stop any of the medications that he's on, like bronchodilators, like oxygen, like antibiotics or steroids, but a small dose of morphine thoroughly improves quality of life. And there is so many patients of mine who come on a wheelchair. With morphine, they're able to walk from the outside the hospital to the clinic room, and they're very grateful for that, because then they can do small activities which gives them joy and pleasure, and that's the least we can do for our patients. So it is a great drug. It is safe if used properly. Yes, most pulmonologists in the beginning are shocked. How can you give morphine? It causes respiratory depression, but not in the doses we use in palliative care. It is used in the manner so that the patient is comfortable, and the aim is only comfort. Terminal breathlessness is another very common thing which comes as a part of all patients who die, whether it's lung disease, whether it's heart disease, whether it's CKD. And this is the time we use a continuous infusion of morphine and midazolam so that the patient transitions in peace from life to death. And that also helps the caregivers, because the manner in which the loved one dies is etched in the memory of those who live on. You imagine if you've seen a loved one suffering and really struggling and in distress, that image keeps flashing back in your mind. And that is where we use this subcutaneous infusion, which is given for the patient who have very poor prognosis of probably less than 1 or 2 days. And that can be also called as palliative sedation. The intent is comfort. The intent is not to hasten death. Clear documentation, clear communication, very essential with the family. And the fact that the patient does not want any aggressive life-sustaining treatment, this is only to see to that the patient is not aware of his distressing symptoms before death, and there is good quality of life before death. Any questions or any things in the chat box, Sridevi?
Not yet. No
Anybody
questions.
would like
No.
to say something or share about breathlessness before I go on to other symptoms?
Yeah, we can wait for 1 or 2 minutes.
Yes, please.
People can ask a few questions if they want.
Anybody wants to comment, share some experience, express any reservations? No? Shall I go on to the cough then?
Yes, we can take
So I will
questions.
I will just quickly go through other distressing respiratory symptoms, and cough can be one of them. And although cough is a protective reflex which prevents foreign bodies to enter the lung and also warns the patient that something is not right, distressing persistent cough can be very irritating, disturb sleep, can cause rib fractures, can cause pneumothorax, incontinence, syncope, hernia, etc. And a lot of patients, even with cancer, complain of cough. So we need to realize that cough is not only aligned to respiratory medicine. It can be because of an ENT problem. It can be because of a heart, gastric, psychogenic, drug-induced, and also treatment. For example, certain radiation of the lung can cause fibrosis that leads to cough. So therapeutic causes also can be leading to cough. Now, cough can be various aspects. You have wet, so you need to, I'm sure all of you know how to inquire whether it's in the day, whether it's in the night, whether it's wet, whether it's dry, etc. So once you get to the bottom of the etiology, whether it's coming from the GI or whether it's the heart, etc., you need to obviously focus on that side of treatment. But after patient has been treated, say for the reflux, or say for the congestive cardiac failure, asthma, COPD, interstitial lung disease, when the cough is still persistent, then you need something to centrally suppress the cough. And one of the things we use is, of course, codeine. So we start with the codeine syrup, which also causes constipation. One can also start with, like a medication to assist sleeping. Sometimes that can also suppress the cough. The third thing is opioids. Morphine again can be used in treating distressing cough. And research has shown that even gabapentin, started first in the night, which is an anti-epileptic, has been shown, because gabapentin not only causes drowsiness, therefore, it helps the patient to sleep, but it also helps the patient to settle its cough. So these are the steps that you can take. So first you need to understand why this patient is coughing, treat that optimally. Then you need to escalate it to central suppressants like codeine and morphine. And if not settled with that, then you can even try gabapentin. If it is due to ACE-induced cough, then of course you should discontinue those medications and try and use certain other medications. But important to please remember the stepwise, and every non-pharmacological treatment also can be used, like say hot water or small frequent meals or propped up position, or even patients sometimes benefit with acupuncture, acupressure to deal with cough as a distracting modality. And sometimes psychogenic cough can also be addressed by counselors if everything else has proven to be. Sometimes for attention seeking, there are children who go into distressing, who keep producing that cough. So it's important to come to the etiology of the cough before you start treating it. Then another distressing symptom which we commonly see is the pleural effusion. Now, please remember, recurrently filling pleural effusion is typically seen in cancer patients, and it can be very, very distressing. And it, of course, most common sites are the lung, the breast cancer, which reaches the lung. But please remember, the breathlessness that is caused by that is because of the ventilation perfusion mismatch. But the treatment of that depends on the prognosis of the patient. So the patient is not very advanced in his cancer. So he has a prognosis, say, of more than 4 weeks. You can actually do a indwelling tube, like a pigtail catheter, so that the drainage keeps happening slowly and the patient doesn't have to keep coming back to hospital. But if the patient's prognosis, which is his general condition, his advanced cancer is very poor prognosis, then you can do a one-time aspiration to relieve the collection. At the same time, if you feel that the patient is still going to be breathless, then morphine will help to reduce the breathlessness. So if the patient is already on morphine for the pain of the cancer, then maybe you obviously don't need to prescribe extra additional morphine. That will also take care of the breathlessness. But please remember, it depends on the severity, the performance status of the patient, and the response to the drainage. But it is important to keep the patient comfortable. So once the patient's prognosis is good, you can even think of pleurodesis, which we do by talc or bleomycin to actually seal the two layers of the pleura so that there is no collection of fluid at all. So please remember, it depends on the condition of the patient, the stage of the cancer, and the general physical performance and the Kornofsky scale, that is the performance status of the patient, because we need to look at overall how the patient is going to tolerate the procedure. Hemoptysis, again, it can be very scary to have it. You need to prepare the patient and the family, especially if you think there is going to be hemorrhage. Please tell the family to keep dark towels, because white towels can be scary for the patient, and the sight of blood also can be very scary. And in hemoptysis, unfortunately, you need to prepare the patient and the family to the nearest hospitals where interventions can be done to stop the bleeding. Because in hemoptysis, patients die not just because of blood loss, sometimes they aspirate their own blood and they can die of asphyxiation. So there are various very complex procedures that are done in medical colleges and tertiary level hospitals, like cryotherapy, like brachytherapy, like laser, like bronchial artery embolization. So these need these need hospital setups, and they might not be able to be done at home or a hospice. So those patients who will tend to bleed, you need to prepare them with numbers and contacts where these procedures are done, so that the patient can reach there in time, not for a curative reason for controlling hemoptysis, but even a palliative control for the hemoptysis. The patient needs to be able to reach the hospital. And I just like to touch upon what the pandemic taught pulmonologists, because during the COVID is when it really hit us, when we couldn't see patients, families, and we had patients who used to come in critically ill, or those patients who came and became critically ill, especially in the beginning of the pandemic. We had no clue what hit us. And the pandemic really has taught how important and essential palliative care is, especially for those suffering from a chronic illness. It's very important to document goals of care of these patients, because sometimes it might be totally inaccessible for them to reach the hospital. Hospitals were full with COVID. Their doctors were busy. There was no doctor available. There was no way to reach the hospital. It was important to get palliative care across to people's home. It was a humanitarian crisis which affected everybody, the rich, the poor, the haves and the have-nots. And pandemic got death and dying into sharp focus. And therefore, if we had all been trained in palliative care pre-pandemic, I think doctors also would have handled it much better, because we doctors also struggled a lot. There was a lot of burnout, there was a lot of compassion fatigue, and there was so much complicated grief and bereavement, with families having multiple losses. I mean, we cannot forget that those 2 years we suffered till the vaccines came up, of how important it is to address palliative care, because all of us went through so much stress and trauma. Therefore, with COVID patients, it became even more important to select patients appropriately to the ICU, deal with medical ethics, who should go to ICU, who should not go to ICU, and the communication between patients and caregivers became extremely important. And like Devi mentioned, the pandemic time was the busiest for us, where we actually advised elderly with severe COVID to not be put on ventilators, or young people who had multiple comorbidities, we actually withdrew them from ventilators so that it was available for others. So this is a whole nother chapter, but very, very important that palliative care can be implemented in all stages, from the house to the outpatient, to the emergency, to the casualty, to the intensive care, as well as in patient wards. So we really need to have the skill of identifying which patients are doing better and which patients are not, appropriately talk to the relatives at the appropriate time in a sensitive manner, so that we do what is in the best interest of our patients. I think with that, I can stop sharing and given you an overview of how pulmonologists will gain immensely by including palliative care, not just to improve the quality of life of their patients, but also handhold the caregivers so that they take the right decision of what to do with their patients in an emergency, especially when the disease is incurable, progressive, and there is going to be no use of futile medical aggressive treatments. So it is still the birthright of patients to be comfortable, and that's where palliative care physicians have a huge role to see to it that we handhold the relatives and the patients in a journey which is difficult, even though we are not able to change the outcome. So I'm opening the floor for questions, comments, and of course, Sri Devi for the case.
Thank you, Rajam, for the wonderful knowledge sharing for last almost 1 hour. We'll wait for 1 or 2 minutes so that people can think and ask questions if they have some. Yes, Dr. Vandana.
Good afternoon, ma'am.
Hi.
Ma'am, I just wanted to know, whenever we are starting the patients on codeine for cough, because that is an old point, and suppose we want to treat the patient for breathlessness, we start the patient on morphine. Is there any decrease in the dose, or is there any change in what we are actually giving when we are treating the symptom as a single symptom and when we are treating it as a combination?
So morphine actually also helps in refractory cough. So if
Yes, ma'am.
you are going to give the patient morphine for breathlessness, you can then assess whether the cough has decreased, okay, and tell the patient to try non-pharmacological things for the cough, or use codeine SOS, or you can add the gabapentin in the night. There's no point giving codeine and morphine. So if the patient's
Yeah.
breathlessness, if you're giving morphine for the patient's breathlessness, in your follow-up visits, you can always ask, is the cough better? Has it improved? If it hasn't improved, you suggest certain more non-pharmacological and slowly make the codeine SOS, because both these are constipating agents, including gabapentin, because then patients stop these medications because they're constipated. So the purpose is completely not addressed. Patient continues to remain breathless and he says it's better I pass stools rather than it's okay if I'm breathless, because that's something he's used to. So you need to convince, and you really need to add the prescription with the first syrup of codeine or morphine. The smallest dose of morphine causes constipation.
Yes. No. Thank you.
Thanks. There's a question from Revati. No, there's many questions. Mm, guidelines
I
for
think
decision making in palliative reference is good. Yeah, okay. Any specific management for lung fibrosis collapse, especially post COVID? So, lung fibrosis is what we have seen is 1/3 of the patients resolve in 12 weeks. 1/3 of the patients remain the same, and 1/3 of the patients progress. So the ones who progress, we treat them like any advanced interstitial lung disease, and we, give them symptomatic treatment for more with morphine, counseling, etc. The 1/3 who resolve, we don't give them anything. The ones who remain, there is a small role for antifibrotics. So we do use pirfenidone and nintedanib, which has been recommended for delay in fibrosis. So the ones who continue to remain the same, the CT scan shows the post-COVID fibrosis, who are symptomatic with lung function deterioration, as well as require breathless on minimal exertion. Those we have tried to use antifibrotics so that the fibrosis is delayed. But in a minimum gap, if you follow up your COVID patients for up to 12 weeks, 1/3 of the patients do seem to resolve of the COVID fibrosis.
Dr.
Does it
Sarah?
answer your question?
Sorry.
Sarah, I think, wanted to ask.
Yeah, hello, hi. Actually, I wanted to know.
Yeah, sorry.
So you were saying something.
I was thanking Ian for his comment, because he has said about morphine for breathlessness, and he said he might not be able to, be there because of his network. Anyway, go ahead, Sarah. Sorry.
Okay, yeah. So I was saying, what is the role of corticosteroids? Like in COVID, also I noticed I was a student and I noticed that people used to give corticosteroids. And is there a role of cortisol in breathlessness? And how do we dose titration? How do we do those?
So there are two different answers here. Corticosteroids is the most potent anti-inflammatory known to man. Okay, the body also produces corticosteroids. The pathophysiology of airway disease in the lung, which is asthma and COPD, both cause intense inflammation of the airway. So if you cut open the cross section of the bronchus of an asthmatic and a COPD, there is intense inflammation. That is why corticosteroids helps in patients with acute exacerbation of asthma and acute exacerbation of COPD. And that's why if you see the GINA guidelines for asthma, as well as the gold standard guidelines for management of COPD, they advocate low dose inhaled corticosteroids as the preventative inhaler for management of asthma and COPD. Okay, come to COVID. In COVID, steroids acted as a life-saving medication. It actually helped survival, because COVID was the novel COVID-19 virus that entered the lung. Human race was not aware of this bug. So it reacted violently to this new bug and created intense inflammatory markers. So there was cytokine, there was leukotrienes, and therefore giving steroids actually was the game changer in these patients. So we lost a lot of patients in the first wave of COVID because this is what we didn't understand, the cytokine storm. So in COVID, steroids actually attacked the cytokine storm because our own body was creating all that. Steroids therefore was given as an immunosuppression. So saying, hello, relax, let us treat the lung, you don't react so violently. So the rationale for steroids in COVID was to prevent the cytokine storm, which used to come in the second week of the infection because the body is getting used to this, that, and the other. But in the rationale of using it in airway disease is as an anti-inflammatory because the pathophysiology is bronchitis, itis, which is inflammation. So there are two different things, and the rationale and the pathology is two different. So in the cytokine storm, we use a whopping dose of steroids. It's a high dose which is given, and then slowly tapered off. While even in asthma and COPD, in the acute exacerbation, we give hydrocortisone, F-colin, 100 milligrams 3 times a day and slowly taper it, but maintain it with inhaler because that was the airway disease. It gets controlled with inhalers. Cytokine storm is a parenchymal disease. That's why it led to fibrosis and interstitial lung disease. Yeah.
We'll move on to the case presentation and then discuss. Dr. Sarah, you are about to ask something. Please go ahead.
No, I was just thanking for the guidance and information. I'm done. Thank you.
Thank you, Sarah. We'll just move on to the case presentation and then we'll come back to the discussion. Dr. Rishikesh.
Hello, I'm Rishikesh Chaudhary. I'm going to present a case today. And my internet is a bit spotty, so if there are any issues, please kindly let me know. So I'm presenting a case of a 85-year-old lady who has been diagnosed as a metastatic lung nodule from previous periampullary carcinoma. Her presenting complaints were cough, breathlessness, episodes of confusion, episodic trigeminal neuralgia, and constipation. So her history of illness, she's a known case of periampullary carcinoma, diagnosed 3 years back, and had taken chemotherapy and radiotherapy as advised then, and was in clinical remission and on remission on PET scan done 3 years ago. So 5 months back, she had cough, breathlessness, confusion that increased over 4 days. She was admitted and worked up, and consequent investigations revealed a final metastatic node in the right lung lower lobe and a secondary bacterial infection and hyponatremia. She was discharged after a short week-long stay with antibiotic course and sodium correction, and the patient came home feeling symptomatically better. Since then, there has been gradual worsening of her cough and breathlessness, with 1 to 2 exacerbations per day, completely limiting her to the bed for the last 2 months. She has had symptoms of trigeminal neuralgia for multiple years now, but the exacerbations have now increased to 1 to 2 times per day. She is unable to move, talk, or eat during exacerbations that typically lasted 20 to 30 minutes. Episodes of increased drowsiness, confusion, and disorientation were present 2 to 4 times a month since the last 2 months. There was a unilateral lower limb swelling noted about a month ago, which was now resolved. And constipation has been increased, and she passes stools with difficulty once in 3 to 4 days. On examination, her BP is 144 by 88, pulse of 98 per minute, respiratory rate of 35 cycles per minute at rest. She has pallor and mild bilateral pedal edema. There's a grade 1 bed sore on the right greater trochanter. In the chest, there are right lower zone crepitations, and during exacerbations, there's also bilateral peace present. In the investigations, her hemoglobin was 10.8 and her sodium was 128. I did not include the rest of the investigations. She had received 3 courses of antibiotics in the last 4 months, 2 oral and 1 home-based IV for urinary tract infections. And she has also been taken aspirin since the unilateral limb swelling when D-dimer levels were raised at that time. So psychosocial aspects, the patient and the family were well aware and accepting of the diagnosis as well as the prognosis. Both were willing for home-based management as best possible. Patient's primary caretakers are her son and his family, and the decision maker is her son. They have the same opinion on the general picture. The patient wants her son to make decisions over the details such as treatment options. The patient is accepting of death, believes she has lived a long and fulfilling life, feels that the suffering she and her family are facing since she is bedridden is futile, and she wishes that God take her away soon. She's spiritually connected. She sings along to the artis when she can or when her breathlessness is not very bad, and she likes for it to be played even when she can't. She's uncomfortable with using diapers but prefers it over soiling her clothes. And she misses her hometown but prefers to stay in the city with her son. And medications, she was on, I would honestly say, a polypharmacy regimen. Nebulizations of budesonide twice a day with salbutamol and saline as required. So these were scattered around the clock. Cough syrups, she took codeine containing cough syrup thrice a day, dextromethorphan containing cough syrup twice a day, and other herbal cough syrups as required if there is additional cough. She was taking tramadol plus paracetamol combination tablet twice a day and carbamazepine 100 milligram twice a day for the trigeminal neuralgia. She was taking sodium chloride tablets thrice a day and tolvaptan once a day, and aspirin and omeprazole was also ongoing. The main concern was the management of cough, breathlessness, neuralgia, and constipation. And the family had a concern of fear of using a dangerous drug, morphine, and they wanted to defer till pain or distress was reasonable. Wanted to defer it till the pain or distress was intolerable for the patient. Sorry about that. And fear of worsening of constipation and drowsiness with additional opiate use was also present. So, to summarize, she's a 84-year-old bedridden lady with a metastatic lung nodule from a primary periampullary carcinoma with distressing cough and breathlessness, constipation, exacerbations of trigeminal neuralgia, and repeated episodes of confusion. So these are the discussion points I came up with. So alleviating fears about the opiate-based medications to a patient and family, and also rational use of opiates. Assessing patients and treating, understanding the caretakers. Okay, so I'll just have to read through it again. But using the what works strategy and balancing it with evidence-based or standard practices.
To Rishikesh, thank you for that. Tell me, why is this patient breathless? Cause of breathlessness.
So
can one nodule cause breathlessness?
I think it could have led to associated edema that might have caused her breathlessness.
People live with one lung.
Yeah.
So what is the cause of breathlessness? Can you think? All of you can put your heads together.
So
First of all, you start with the age. What happens at 85? Why was she bedridden?
She was bedridden because of the inability to walk around. Walking around made her breathless, and one factor could be age, leading to lower muscular
What
strength.
happens to you and me if we lie in the bed for 2 months?
Wasting of muscles that are not used.
So what is that condition called?
Deconditioning.
Deconditioning, no? We get deconditioned.
Oh, okay.
So for example, if you classify all those people who get breathless, are breathless because of lung problem, breathless because of heart, or breathless because of deconditioning. Then you can classify everything into this. For example, so all your respiratory, cardiac, you know the causes. But even an advanced cancer patient, because of the loss of muscle, that's why we call it anorexia cachexia syndrome. So even the breathless patients are breathless because there's loss of muscle mass. That's deconditioned human being. So that is the reason she is breathless. Why am I asking you this question? Also, of course, age related, there can be muscle loss. The nodule cannot be the cause of her breathlessness. Only cause. Okay. It has to be deconditioning. The other thing that it could be anemia of the ampullary CA or whatever. So that could also cause the breathlessness. It could be anxiety that can cause the breathlessness. Why am I bringing this into focus? Is because of your drug chart. Can we go to the drug chart? So with this information, with the pathophysiology of the breathlessness clear, what would you stop? Why are you giving her saline? Is she bringing up secretions? I'm just saying, this is devil's advocate. This is to learn the other way around.
So I think basically what happened is in the what works, let's follow what works strategy. Nebulization gave temporary relief for a half an hour to 1 hour. So it was preferred by the patient as
Do
well.
you know what happens when you give salbutamol to a person orally? Have you ever taken, my MD teacher used to ask us to take 1 tablespoon of salbutamol before writing it to a patient's prescription. It really gives you the shivers. Oral salbutamol is in milligram doses. It is horrible to take it. What do we give inhaler is microgram doses, which is 1,000th of a milligram. It's an extremely uncomfortable feeling to take deriphyllin or salbutamol orally. So that oral salbutamol is something that you should never prescribe, not in the 21st century, not ever. So when you have these cough syrups, which gives terbutaline, they all cause tremors. So please don't, it makes you really feel out of your skin. Second thing is you've also given codeine, which is fine. Budesonide. Now, this is a steroid inhaler. I know you heard the V's. That's the other thing that is questionable because this lady never had any airway disease, right? Did she?
Yep. No.
Yeah.
So
it's a symptomatic, sorry, yeah. Sorry.
She had a past COVID infection, but no other chronic.
COVID infection will not cause it. You can give inhaler, no? And active COVID infection, may we have been giving Budecort.
Yeah.
Chronic COVID, there is no role because airways are fine. It's an interstitial. So in this situation, her breathlessness would have probably multi-pronged attack of counseling, see if she's anemic. So then you accept certain level of breathlessness and morphine would have probably helped. And then this pain is managed, that tramadol, PCM also can go. Now, elderly with tramadol is another some combination that I am scared of because they really end up with a lot of nausea. So I'm just trying to highlight whenever you have a patient of breathlessness, find out why this patient is breathless, whether it's respiratory, whether it's cardiac, whether there is something else, because accordingly you optimize the treatment for that and then assess for chronic breathlessness. So 85-year-old with no history of the heart, no history of the lung will not benefit with nebulizer. It's unnecessary waste of a pharmacological drug. Okay? This is my whole. Suppose the patient has reflux. Then you see to it that the patient eats small, frequent meals, early light dinner, propped up position, then give a domperidone so that the stomach is empty. So assess the cause for breathlessness. All patients who are breathless are everything that wheezes is not asthma. So very important. Accordingly, you can target your treatment therapies. Now coming back to your other concerns. Anybody wants to add anything to this?
What might have caused the wheeze in this case?
So see, that is another thing. So wheeze is actually a symptom. It could even be an upper airway problem. So what you assess as a sign is the rhonchi. So that could be a congestive cardiac failure, no? At 85, she could have had a cardiac event. Did we assess for that? So even if the heart is not pumping adequately, that also can cause alveolar edema and wheeze.
Yep.
So maybe a low dose diuretic would have helped.
Okay.
So at 85, you can expect all other organs also to have did she have a CKD issue? That can also cause a wheeze because of extra fluid overload. So small things. So get to the bottom. Yet if you feel the patient is getting relief in palliative care, we will continue. I'm only saying the rationale should be there, that you have tried to evaluate the reasons for the appropriate cause of breathlessness or cause of chest pain or cause of ABC, and then target the therapy. In this case, salbutamol SOS is totally not needed. Steroids is probably not needed. Yes, control of breathlessness, after you evaluated everything, you can give morphine. Revati has written benzodiazepines and lorazepam. That is again if there's anxiety as a part of, so the counselor needs to tell us whether that's an issue, then you can add that. Because again, one of the concerns that the relatives had is drowsiness. And with benzodiazepine and lorazepam, the patient will sleep. So this is another very important thing which, very often even Sridevi will agree with me that patients, relatives want the patient to be aware and awake. The whole idea of palliative care is to see to it that the patient is awake and not aware of his symptoms. So you titrate according to that the patient is comfortable. And if the patient is uncomfortable being awake, then unresponsive is better than experiencing distressing symptoms. But that is something that comes with constant communication with the relatives. Okay, so your discussion points was that, right?
Yeah.
Suffering limits. So, this is another very culturally a very important thing in India, that we are all said we should not complain of pain or complain too much. We should bear the pain. But nobody gives you a medal, and at 85, the frail old lady needs to be comfortable. So it is an attitude. When it comes to the son and the daughter becoming in that position, they will bring the roof down if they're uncomfortable. So culturally also, the pain concept is very differently appreciated in Southeast Asia as regards to the West. In India, we will all say the patient is a very good patient because patient doesn't complain. But it's a patient's right to be comfortable. So this is something that we should discuss in the constant communication. So very important to, yes, use evidence-based, but sometimes patients comfort, sometimes, all the time, patients comfort, especially in a advanced stage or towards end of life or towards terminal, takes top priority. So we do certain things which focus only on patient comfort and that has to be prioritized. And along with that, communication with the relatives so that the relatives are comfortable. Otherwise, they are happy to complain that, I was not heard or I was not listened to. Any thoughts or any comments?
Any comments from the participants?
I have a question. May I
Yes.
ask? Yeah, actually, it's not related to the case discussion, but my question was regarding pleurodesis for malignant pleural effusion.
Yes.
In case a patient has more than 4 weeks of expected survival, but what are the intrathoracic factors that we look for, which can give us an indication that pleurodesis may not work in a
There are
case?
you cannot judge. You have to try by giving talc or bleomycin. And when it works, it really does a good job. So if it's done in a good setup with an intercostal drain, it really works very well for the patient. There are very few things that we can do to say that it will not work. It's a question of trying and finding out.
Sure. Okay, thank you, ma'am.
Any other questions, Sridevi?
Nothing in the chat.
On the chat, yeah. If anybody wants to ask something, if you can stop sharing, then we can see. Anything else, Rishikesh, you would like to discuss about the patient?
Nothing specific. If there are any questions, so then I can, if there's more information, then I can provide it and then based on it. But
So did you want to discuss anything more or different with your patient?
No, not at this point, no.
So what is all your background? Are you working in hospitals or private, or how often do you come across patients where you feel I'm not doing the right thing, the patient should not be going to ICU? What else can I do without sending the patient to ICU? So how many of you work in hospitals?
I am an MBBS graduate and I saw this patient in a personal, it's a second degree relative family, and I was just there. Like I was not involved in the decision making or treatment here.
But so let me flip the question the other way around. Do you think having this information that you're gaining from this Pallium India course will now make you see patients differently?
Absolutely. Like I will be more rational in my approach, and I would be more comfortable with uh, ident prescribing drugs as well as identifying what are irrational combinations and advising them to change those therapies.
Yeah, I mean, that's the purpose solved, because we need to, what we know now is to tell patients what not to do. But now with this, you are armed with information of what you can do at home and yet maintain comfort at home. And that's the whole purpose of identifying the fact that there is another approach to treating patients who do not have a cure to their chronic life limiting illnesses. So that's the whole purpose of this thing. Sridevi, would you like to add something?
That was a very relevant question that you asked. So I was just writing it down because that's the most important thing that we want to know. Is it going to change the way they treat the patients after this, even in terms of breathlessness also? Will
So,
they
you know,
start
one of the
treating
things
differently?
that we have tried to do, Sridevi, after a session is head, hand, and heart. You know, how much of they understood, therefore, how much of it will change their first, and how much will they do. So it really makes a difference, because you know, when you learn about chronic breathlessness, you know, the first time when you prescribe morphine to a breathless patient, you get a lot of backlash, because everybody will like saying, what are you doing, you're killing the patient, XYZ. So the whole concept of giving them the articles of how morphine can benefit with chronic breathlessness and how it changes it, and you have to see it to believe it. And I have changed as a pulmonologist since I've come to palliative care, and therefore, you know, really advocate assessing your patients, evaluating it, see to that they're taking all optimal medications, and low dose morphine really makes a big difference if you include it along with non-pharmacological techniques. Did you want to say anything, Jaya? I saw you nodding something. So the threshold for use of morphine should reduce in respiratory palliation. Yes, but at the same time, please evaluate your patients correctly. Please communicate to the relatives correctly, and when you put the patient of morphine, please follow up the patients regularly. So I have a register of which patients I have put along with their numbers, because it should not be that they're taking morphine indefinitely, even without feeling better, or they should report to you if they're not feeling better and feeling better, so that you know that you're doing the right thing. And you, at any given point of time, should know which patients you have put on morphine and how they are faring, and have the GP involved or have the primary consultant involved, so that it's a team decision, not a unilateral decision. It has to be communicated well.
I think Dr. Mohammed Sajid has asked the second question related to that. Should we investigate them in detail?
What is the meaning of investigate? See,
Yeah.
they have always been patients who are, these are patients with chronic respiratory illness. So they should have had, should have had a pulmonologist, they should have had a PFT, they should have had a CT, they should have had an ABG and a diagnosis of COPD or diagnosis of interstitial lung. Then you assess their functionality, unable to walk, on 24/7 oxygen, so many other things. Then as a palliative care physician, you need to evaluate about how it has affected their lives, and how, if they're breathless at rest or minimal activity, and then you try the morphine and see if it makes a difference. And if it makes a difference, then you have one, obviously have this uh, enough proof that you should continue the low dose morphine. So there's a ceiling dose when you use morphine for breathlessness. It's not that you keep increasing. You need to evaluate these patients and be in touch with them, even if it is by a telephone call or a message. You need to be in touch with the patient. So these patients will never come to you in the beginning. Pulmonologists will not part with them in the beginning. Please remember, they will come with you only if the patient keeps coming back to their casualty, keep frustrated. What else can I do? I cannot do anything more than this. None of these patients will come to you at the time of diagnosis. No pulmonologist is evolved to start the patient's palliative care referral in the beginning. So in the beginning, the onus is on the pulmonologist to make the diagnosis. As a palliative care physician, you need to handhold them when the symptoms are so much so that despite being on optimum drugs prescribed by pulmonologists, the patient continues to be breathless. Please don't use morphine lightly. We don't want to go the America way where they're abusing morphine, and now there's strict rules and regulation of who could prescribe how much morphine for how long. We don't want that. Yet, we still need to see to it that our patients don't suffer. It has to be patient driven.
Thank you, Raju. Any other question from anyone else?
So either I have been crystal clear, which I hope I have been,
Yes,
or
yes,
they
you
are
were.
stunned, or they are stunned to silence.
You were clear, but I thought there will be more questions, especially breathlessness, because there are usual questions that people ask when it comes to breathlessness.
So have they had many sessions already?
Yeah, 12. This is the 13th session. So they have done with GI symptoms and pain. The next symptom that we are. I think there are no more questions, so that we can wind up today's session. Thank you so much, all the participants, for the questions, and Dr. Rishikesh for bringing in the presentation. I thought this was very relevant for today's session. That's why we asked you to take up the presentation today. Thank you so much, Rajam, as usual, for
Thank
coming
you.
again.
Thank you. And please, I don't know, maybe you already shared the blue maple and the
Yeah, we will be doing
and
it.
the gold standard framework, because it really, those are two good papers to refer in
Yes.
general of when to refer patients to palliative care.
Yes.
And you can have healthy arguments during your rounds in hospitals.
Yes. Thank you so much, Rajam, and thank you so
Thank
much,
you.
all the participants.
Thank you.
See you next
Bye.
session.
Thank you.
Thank you. Thank you, everyone.